the Medicare Part D lie that steals your $10,000 drug savings. The $10,000 prescription lie hook. You're not crazy. Your Medicare Part D bill looked harmless on paper and nasty at the register. The lie isn't that Part D doesn't work. It's how plans present costs, so you underestimate what you'll actually pay. In 2025, there's a $2,000 cap, $35 insulin, and $0 vaccines. And still, people are overpaying by thousands before they hit the cap. Why? Deductible tricks, tier games, and preferred pharmacies that aren't. Today, I'll show you the exact 2025 rules, the traps that trigger five-figure losses over a few years, and how to lock in the lowest total annual cost so you keep money for groceries, heat, and family visits without changing your doctor or meds. Part D in 2025, what changed and why it matters. Let's set the record straight on 2025. Yes, there's a hard $2,000 cap on what you pay out of pocket for covered Part D drugs. That's huge. But plans still control how fast you get there and how much pain you feel before you do. That's where the money leaks out and where people lose grocery money, skip trips, or delay care. We're not letting that happen. Here's the clean version. Before 2025, you had 4 stages: deductible, initial coverage, the coverage gap, the donut hole, and catastrophic coverage with 5% coinsurance. In 2025, that final 5% is gone. Once your true out-of-pocket hits $2,000 for covered Part D drugs, your cost sharing drops to $0 for the rest of the calendar year. Plans and manufacturers still pay on the back end, but you don't. That's the finish line. Now, the subtle part most people miss. The finish line helps, but the race still costs money. Plans differ wildly in deductibles, tiers, and pharmacy networks. So two people with the same drugs can pay very different amounts getting to that same $2,000. A bad plan makes you shoulder more of the journey. A good plan pushes more cost earlier to the plan and gets you to dollars sooner with fewer nasty surprises. Insulin users get an extra layer of protection. A $35 maximum per month for each covered insulin product, no matter what stage you're in. That applies even if you haven't met your deductible. Vaccines recommended by ACIP are $0, shingles, staph, pneumococcal, and others. These are straightforward wins that keep you healthy without surprise bills. Deductibles still exist and matter. Many plans apply the deductible to Tier 3 and above, while waiving it for Tier 1 and Tier 2 generics. If you only looked at the premium and ignored deductibles, coinsurance, and pharmacy status, that cheap plan can be brutally expensive on a brand drug in Tier 3. The trick is knowing whether your medications hit the deductible and what your share is after it. Tiers are not universal. A drug can be Tier 3 on one plan and Tier 4 on another. That shift alone can double or triple your copay or bump you from a copay into coinsurance. Tiering exceptions exist, but they aren't guaranteed, can require strong doctor documentation, and sometimes expire. You can't plan your year on a maybe. Pharmacy networks are a silent price lever. Preferred pharmacies inside the same plan often deliver lower prices than standard pharmacies. Mail order is not automatically cheaper. In 2025, with a cap in play, network differences still decide how much you pay before you reach $2,000. If your favorite pharmacy is standard and the plan's preferred option is across the street, that short walk might be worth a few $100s. Utilization management, prior authorization, step therapy, quantity limits hasn't gone anywhere. In fact, expect plans to tighten these on expensive brands and biologics now that patient cost sharing ends sooner. That means more paperwork and potential delays. If your drug gets a new prior authorization mid-year, you could face temporary cash prices or a forced switch unless your prescriber pushes back quickly. Formularies can change during the year with proper notice. A drug can move up a tier or new restrictions can appear. you might get a transition fill, but your costs can still spike afterward. This is another reason you should check plan notices and run the numbers again if your meds change mid-year. Now, about that cap, there's also a smoothing program, an option to spread your out-of-pocket across the year so you don't get slammed early. If cash flow is tight, you can opt in with your plan. The total you owe for the year doesn't change. It just gets divided into manageable monthly amounts. For someone hitting $2,000 in March, this can turn a scary spring into a steady budget and prevent choosing between meds and utilities. Here's the mental model. Think time to cap and cost before cap. Time to cap depends on drug costs, plan tiering, and negotiated prices at your chosen pharmacy. Cost before cap is the combination of deductible, copays or coinsurance, and network pricing you face on the way. Two plans with the same premium can differ by hundreds to thousands on that journey. The cap is a seatbelt, not a chauffeur. A few quick examples. If you're on a high-cost oral cancer drug covered under Part D, you might reach $2,000 early in the year. Your focus is cash flow, prior authorization, and making sure fills count toward your cap. If you're on an inhaler in Tier 3 and a brand anticoagulant, the right plan and preferred pharmacy can shave hundreds before you hit $2,000. If you're insulin dependent, confirm each insulin product is capped at $35 and check whether a preferred pharmacy offers a $1 copay on select insulins. The reason this matters, you can't set and forget Part D just because the catastrophic 5% is gone. Plans are betting you'll glance at the premium, feel good about the cap, and ignore the mechanics. Don't. In 15 minutes on Plan Finder, you can see your total drug plus premium cost for the year, compare pharmacies, and spot deductible exposure and restrictions. That single check often saves a car payment's worth of money and the stress that comes with surprise bills. Bottom line, 2025 protects the finish line, but the starting line and the path are still booby-trapped. If you remember nothing else, remember this. Compare total annual cost for your exact drugs at preferred pharmacies, opt into smoothing if you need it, and never assume tiers or mail order are in your favor until you verify. Do this now, not later. The longer the leaks run, the more you lose. The 7 hidden cost leaks, most people Mississippi. Let's get tactical. These are the leaks that quietly push your pre-cap spending hundreds to thousands higher, even though you've got the same drugs and the same $2,000 finish line as your neighbor. Fixing them puts that money back toward real life needs, not plan games. Leak 1, low premium, high deductible math. The thing most people miss is how a $0 to $10 premium plan often pairs with a full deductible that hits Tier 3 and above. If you take even one brand, you eat the deductible first, then coinsurance. That's how you save $120 a year on premium and lose $800 to $1,800 before spring. How to plug it. When you're on Plan Finder, scan the deductible applies to tiers line, then click your brand and read the per fill cost estimate for January and March. If January shows a giant number, that low premium is a mirage. Leak 2, preferred versus standard pharmacy pricing. Same plan, wildly different bills. The reason this works is negotiated rates are pharmacy specific. A preferred contract often means lower member cost sharing. Standard can be double. You wouldn't pay twice for gas next door. Don't do it for meds. How to plug it. Test 2 retailers and 1 grocery or big box chain. Toggle the pharmacy selection and watch your annual total shift. If your local is standard, ask if they have a sister location in the same chain that's preferred. A 5-minute switch can save a few $100s. Leak 3, mail order assumptions. Mail order can be great for generics and stable maintenance meds, but I keep seeing the mistake where folks auto-enroll and pay more. Plans sometimes price 90-day mail higher than 3 30-day retail fills at a preferred store. The shortcut nobody teaches. Compare 30-day preferred retail versus 90-day mail on each drug. If one is cheaper retail and another is cheaper by mail, split your strategy. There's no rule that says every medication has to ship in a box. Leak 4, coinsurance versus copay trap. Coinsurance looks harmless until the allowed price fluctuates. 1 month, 25% of $480. The next, 25% of $560. Your cost moves, and you can't predict it. Copays are steady. Once you nail this, everything else clicks. Prioritize plans that offer flat copays on your specific tier 3 drugs instead of percentage coinsurance. Ask your plan to run a real-time benefit check for your exact NDC at a preferred pharmacy. If the plan's best option is still coinsurance, make sure the negotiated price is favorable compared to competitors. Leak 5, deductible exemption gaps. Here's where most people mess up. A plan might advertise deductible waived on tiers 1 to 2, and you assume you're safe, but your inhaler or anticoagulant lives in tier 3, so you're still exposed. The quick check. Look at your med's tier number, not just the tier name. If it's 3 or higher, you're likely paying the deductible on that drug. Consider a plan with a smaller deductible or better tier placement for that exact med. Sometimes a $5 higher premium saves hundreds by January. Leak 6, mid-year formulary tweaks that stick. Plans can move a drug up a tier or add prior authorization with notice. The cost leak isn't only the higher copay, it's the delay that forces a cash fill or skip dose. My micro story, last quarter, a viewer's inhaler moved tiers mid-year. They called, got a transition fill, and their doctor sent notes for a tiering exception. Approval cut their per fill by $48 and prevented a cash price disaster. The move: save every notice, and when anything changes, immediately request a transition fill. And file an exception with your prescriber's letter. Time kills money here. Leak 7, authorized generics and biosimilars left on the table. The thing most people miss is that an authorized generic or a favored biosimilar can sit on a lower tier with a flat copay, while the brand sits higher with coinsurance. If your doctor says clinically appropriate, switching to the plan's preferred version can bring you to the $2,000 faster with less pain. How to plug it? Ask your prescriber, is there an authorized generic or preferred biosimilar you're comfortable with? Then confirm the tier and per fill price with your plan at a preferred pharmacy. If it's cheaper, ask for a new script using the exact product name. 2 bonus microleaks I see all the time. 1, skipping the smoothing program and getting crushed in February. If you'll reach the cap, smoothing turns a $900 spike into a predictable monthly payment. 2, ignoring quantity options. Sometimes 2 30-day fills are cheaper than 1 90-day, or the plan prices a 90-day at a lower effective rate. Always compare both patterns on your top 2 meds. If you remember nothing else, remember this: stop assuming, start verifying. Premium, deductible, tier, pharmacy, and quantity each have a lever. Pull them in your favor, and your pre-cap spending drops fast. Refill calendar engineering, the timing fix. This is the game changer nobody talks about. You can cut hundreds off your pre-cap spending just by engineering when and how your refills hit. Not changing drugs, not switching doctors, just timing. The reason this works is simple. Deductibles, copays, and negotiated prices behave differently in January versus March, and 30-day versus 90-day fills hit your out-of-pocket in very different ways. So let's build a refill calendar that pushes pain down and pulls savings up, so you're not choosing between meds and groceries. Start with a blank month-by-month grid for the year. Write each medication, dose, and typical refill frequency. Circle the brand name drugs or any tier 3+. Those are your priority. Now mark your plan's deductible if it applies to those tiers. Your goal is to control, when you trip the deductible, and how many expensive fills you hit before smoothing or the $2,000 cap kicks in. Here's the foundational move. Align expensive meds on the same calendar month early, then spread routine generics later. If you'll hit the cap by spring, it's smarter to cluster the high-cost fills in January, March, so they count toward your $2,000 faster. That way, you shift more of the year into dollar cost sharing sooner. If cash flow is tight, pair this with the smoothing program, so those early hits get converted into steady monthly payments instead of spikes. Now, the 30-day versus 90-day decision. For generics, 90-day fills often save money and reduce trips. For brand drugs with coinsurance, 90-day can sometimes cost more than 3 30-day fills at a preferred pharmacy. The shortcut nobody teaches. For each brand, ask your plan to run 2 test claims, 30-day preferred retail and 90-day mail and retail if available. If 90-day is pricier, stick to monthly. If 90-day is cheaper and predictable, lock it in and set reminders. Quantity alignment matters next. Before your deductible is met, each fill of a deductible-affected drug hits you harder. So if you're going to meet the deductible anyway, it's often better to do it with the fewest number of fills. One larger quantity can clear more of the deductible in a single swipe. But, and this is critical, only if the per unit price makes sense. Sometimes 230-day fills price lower than 160-day or 90-day. That's why you always compare the actual per fill numbers before making the move. Timing around vacations and appointments can save, too. If your doctor visit falls mid-month, ask for the new script a few days earlier so your pharmacy can process it in the same billing cycle as your other expensive meds. Stacking high-cost fills in the same month accelerates you toward the cap. The opposite is also true. If you won't hit the cap this year, consider staggering your brand fills so they don't collide with each other or with the month your deductible resets. Here's a clean example. You take a Tier 3 inhaler, a brand anticoagulant, and 2 generics. Your plan's deductible applies to Tier 3 Plus. You opt into smoothing in January. You request both brand scripts to refill the first week of January and set the generics for mid-month 90-day fills. Result, your smoothing starts immediately, your big costs count toward the cap ASAP, and your generics don't push your January bill higher than needed. Less stress, more control. Pharmacy calendars help. Preferred pharmacies sometimes offer auto refill cycles that can be shifted. Ask your pharmacist, can we move these 2 brand refills to the first week of the month and push this generic to the 3rd week? Most systems allow it within clinical limits. If a drug has a quantity limit, request your doctor to align the day supply so it refills on the same monthly cadence as your other expensive meds. Mid-year changes? Re-engineer. If your drug moves tiers in June or gets prior authorization, call immediately for a transition fill. Then ask your prescriber to submit exception paperwork. While that's pending, realign your other refills to avoid stacking unexpected cash prices in the same month. The quick test. If this brand costs me more in June, which other med can I slide to early July? Mail versus retail timing is another lever. Mail order sometimes ships early and bills at ship date. Retail charges at pickup. If you need a few days to keep all high-cost fills in 1 month, ask the pharmacist to delay pickup within the allowable window. For mail order, schedule shipment after your other brand is processed if it lowers your exposure that month. Set reminders now, 1 for 5 days before each brand refill, and 1 the day your smoothing bill drafts. If anything looks off, call the plan and ask for a real-time benefit check before the pharmacy touches it. Would they keep watching? Yes, because when you run this play, you turn randomness into a calendar that puts dollars back in your pocket. Pharmacy network strategy. Preferred pricing without guesswork. You've already seen how timing cuts costs. Now, let's lock in the second lever. The right pharmacy every time without guesswork. because inside the same plan, your preferred versus standard, pharmacy can swing a brand from affordable to painful. We're going to make that transparent and repeatable, so you never pay the convenience tax again, and you keep dollars for what actually matters. Start with this principle. Preferred beats standard most of the time, but not always, and mail order isn't automatically cheaper. So we use a quick 3-pharmacy test and a real-time verification call. 10 minutes once per year, and a 1-minute check whenever something changes. Step 1. Shortlist your 3 pharmacies. Pick your current favorite, a competing big box or grocery chain that often shows as preferred, and 1 national chain with broad hours. In Medicare's Plan Finder, add all 3 to your comparison. Sort plans by lowest drug plus premium cost, then open your top 2 plan candidates. Toggle the pharmacy dropdown and watch the annual estimate update for each drug. Don't eyeball. Write down the per fill cost for your top 2 brand meds and your largest generic. You're looking for 2 numbers, the cheapest location per drug, and the annual total when you stick to a single location. Now here's where most people mess up. They stop when 1 pharmacy wins overall. Instead, split your strategy if it makes sense. If your anticoagulant is cheapest at the preferred big box, and your inhaler is tied across 2 preferred stores, fill the anticoagulant at the big box and keep everything else where service is best. There's no rule that says all drugs must run through 1 counter. Ask both pharmacies to keep your profile active and to transfer prescriptions on request. Transfers between chains are routine and fast. Before you switch, verify with a real-time benefit check. Call your plan's member services and say, "Can you run a test claim for drug X 30-day supply?" NDC if you have it at Pharmacy A and Pharmacy B. You'll get the exact member price based on your plan's current stage, deductible status, and the plan's negotiated rate. If the quote doesn't match Plan Finder, ask why and get a reference number. Sometimes the discrepancy is a different day supply default or a slightly different NDC. Fix that on the call. Ask your current pharmacy 1 simple question. Are you preferred for my plan? If they're not, ask, is there a location in your chain that is preferred? Often a nearby store in the same brand is preferred while yours isn't. If a 5-minute drive saves $20 per fill on a brand, that's real money. If transportation is an issue, ask about delivery or curbside options at the preferred store. Mail order can still win, but only drug by drug. For each maintenance medication, compare 3 scenarios: 30-day preferred retail, 90-day preferred retail, and 90-day mail. If the 90-day mail price is higher or ties with retail, keep it local for speed and flexibility. If mail order wins on a stable generic, use it. If it's a brand with coinsurance, double-check because a percentage of a fluctuating allowed price can surprise you. The shortcut nobody teaches. Ask your plan, does mail order have a different negotiated rate than preferred retail on this specific drug? Sometimes the answer is yes, sometimes no. Network changes mid-year? Don't panic, pivot. If your pharmacy loses preferred status or a plan update shifts pricing, rerun your 3-pharmacy test. Call the plan for a fresh test claim on your top 2 drugs. Then move the next refill to the newly cheapest preferred option. You can transfer a prescription with 1 call. Controlled substances may require a new script. Ask your prescriber's office to send it directly to the new location. 2 pro moves to squeeze extra savings. 1. Ask your pharmacist to check therapeutic alternatives on lower tiers through their real-time tool. They'll see if a clinically similar drug has better cost sharing at your plan's preferred rate. 2. If you use discount cards for a non-covered drug this month, keep that separate from your Part D medications so you don't confuse the troop math. Then at your next covered fill, confirm your plan applied everything correctly. Finally, bake this into your calendar. Every January, confirm preferred status and rerun the 3-pharmacy test for your top 2 meds. Anytime a price looks off at pickup, pause and call your plan from the counter for a test claim. 10 minutes of precision beats a year of overpaying, and it lowers your blood pressure at the register. Annual Plan Audit, 15-minute tool workflow. This is the fastest way to stop leaks and lock in the lowest total annual cost. You'll use Medicare's Plan Finder, a single page of notes, and one quick verification call. 15 minutes once a year, plus 2 tiny check-ins when something changes. Minute -1, prep your list. Write every medication, exact dose, and how many you fill per month. Add seasonal or occasional meds that matter, like an inhaler you use every winter or eye drops for allergy season. Put a star next to any brand or anything you suspect is Tier 3 or higher. Add your 3 pharmacies, your current store, a likely preferred competitor, and 1 national chain. Minute 1 to 3. Open Medicare.gov and launch Plan Finder. Choose Continue without logging in if you prefer, but an account lets you save your list for next year. Enter your zip, select Part D, and type each drug with dosage and quantity. Important, choose the exact form, strength, and frequency. Small differences change pricing and tiers. When it asks for pharmacies, select all 3 from your shortlist. Minute 3 to 5. Sort by lowest drug plus premium cost. Never sort by premium alone. Open the top 3 plan results in separate tabs. In each tab, toggle the pharmacy dropdown and watch the estimated yearly drug plus premium cost update. Write 3 numbers per plan. Total at Pharmacy A, total at Pharmacy B, and total at Pharmacy C. Now click into your 2 most expensive meds and note the per fill cost in January and in March. This reveals deductible exposure and whether costs stabilize. Minute 5 to 8. Read the deductible and tier rules. On each plan page, find deductible and which tiers are exempt. If your star-marked brands sit in tiers that hit the deductible, highlight that plan in yellow. It needs more scrutiny. Next, look at cost-sharing type. Is it a flat copay or a percentage coinsurance on your brands? Favor the flat copay when possible. It makes your bill predictable. Also scan for prior authorization, step therapy, or quantity limits next to each drug. If any appear, add a question mark to that plan. This is where delays and surprise costs creep in. Minute 8 to 10. Identify the split pharmacy win. For each plan, determine the cheapest location for your most expensive brand and the cheapest for your second most expensive drug. If they're different, circle split fills okay. Your default strategy becomes fill drug A at Pharmacy X and drug B at Pharmacy Y, with generics wherever service is best, usually the cheaper of the 2. Minute 10 to 12. Pressure test with a real-time benefit check. Call the plan's member services line for your top 2 candidate plans. Say, can you run a test claim for drug X 30-day supply at Pharmacy A and Pharmacy B, and the same for drug Y? Verify the member price matches Plan Finder for January. If it doesn't, ask them to confirm the day supply, NDC and stage assumptions, and request a second run. Get a reference number and write it next to the plan name. Minute 12 to 13. Ask for lower tier alternatives. Still on the call, ask, is there a lower tier therapeutic alternative for drug X? If they mention one, write the exact name. Then ask, if my doctor supports it, will you approve a tiering exception? Note any criteria they state, failed therapies, diagnosis codes, or documentation requests. You're not committing. You're learning the quick path if prices spike mid-year. Minute 13 to 14. Decide on smoothing and refill cadence. If your math shows you'll hit $2,000 before summer, add opt into smoothing to your January checklist. Decide 30-day versus 90-day for each drug based on the per fill numbers you captured. If the 90-day price is worse for a brand, stick with monthly. If a 90-day generic is cheaper, lock it in. Minute 14 to 15. Choose and document. Pick the plan with the lowest total cost at a preferred pharmacy setup, the fewest restrictions on your specific drugs, and the most predictable copays. Write plan name, premium deductible rules, per fill prices for your top 2 meds, chosen pharmacy for each, and the call's reference number. Save the plan's evidence of coverage PDF in a folder named Part D 2025 and set a calendar reminder for 2 checkpoints, one after your first fill to confirm prices matched, and one in October to rerun this exact workflow. That's your annual audit. It's simple, repeatable, and it pulls every lever: pharmacy, tiers, deductibles, and timing, so you keep more money in your pocket. Drug optimization, therapeutic alternatives that slash tier costs. Now that your pharmacy and timing are dialed in, the next lever is the drug itself, without changing your diagnosis or lowering your quality of care. We're talking therapeutic alternatives, authorized generics, and plan-favored biosimilars that move you down a tier, swap coinsurance for a flat copay, and get you to the $2,000 cap. With less pain on the way, you keep clinical outcomes, you drop the bill, and the anxiety that comes with it. First, why? Doing this wrong means you're stuck with coinsurance on a high allowed price, and every refill becomes a lottery. Doing this right locks predictable copays and lowers what you pay before smoothing or the cap kicks in. The win is stability and speed, stable monthly costs now, and faster relief when you hit $2,000. Here's the mental model. Same class, same therapeutic effect, better tier. Plans often favor one option in a drug class. If your prescription is the non-favored brand, you pay more. When you switch, only with your prescriber's approval, to the favored equivalent, the price drops. That's the quiet tier cut. Step 1. Identify alternatives by class. List your brand meds and the class they belong to: inhaled corticosteroid/LABA combos, anticoagulants, GLP-1s, SGLT2s, DMARDs, TNF inhibitors, or asthma LAMAs. In each class, there are multiple clinically similar options. The thing most people miss is that plans don't favor the same one. Plan A might love drug X, Plan B loves drug Y. You ride the favorite. Step 2. Authorized generics. These are the brand drug made by the same manufacturer, sold as a generic label. Many plans place them on lower tiers with flat copays. Ask your prescriber, is there an authorized generic for this? If yes, confirm the exact product name and NDC style. Then confirm with your plan at a preferred pharmacy that it's on a lower tier and what the per fill cost is. You want the exact label your plan recognizes. Step 3. Biosimilars versus brands. For biologics like adalimumab, etanercept, and insulin analogs, plans typically name a preferred biosimilar. The reason this works is simple. The plan negotiated a deal. When your prescriber is comfortable switching, the tier usually drops and coinsurance may convert to a copay. Ask your plan, which biosimilar is preferred for my diagnosis? Write the exact name. Then ask your prescriber to review and document medical appropriateness. Step 4. Therapeutic alternatives within a class. Inhalers are a perfect example. If your plan puts your current inhaler at Tier 4 coinsurance, but lists another combination inhaler at Tier 3 with a flat copay, that's your move if your clinician agrees. Same with anticoagulants. If one DOAC sits cheaper on your plan, ask whether it's appropriate for your clinical profile. The shortcut nobody teaches. Have your doctor send a 1-sentence note. Switching to plan preferred, alternative due to lower tier and patient cost. That supports continuity. Now, the practical call script that gets results fast. Call your plan and say, can you run a real-time benefit check for my current drug A and any lower tier therapeutic alternatives at my preferred pharmacy? I want the exact member price today, including deductible status. Then ask, do you have an authorized generic or preferred biosimilar for this therapy? Get names, tiers, and per fill costs. Ask for a reference number. Call your prescriber's office and say, plan shows drug B at Tier 3, flat, copay $47 at preferred pharmacy. Is it appropriate to switch? Keep it specific and grounded in the numbers. Common mistakes to avoid. 1. Assuming all generics behave the same. Authorized generic versus AB-rated generic can have different plan treatment. Verify tier and price. 2. Asking for a switch without checking quantity limits. Some cheaper tiers hide tighter quantity caps. Confirm your dose fits within limits. 3. Ignoring device preference on inhalers. Technique matters. If you switch devices, ask your pharmacist for a quick teach-back. 4. Assuming coupon savings count toward your cap. If you use a manufacturer card outside Part D, it usually won't count toward Troop, great for a cash break now, but it won't speed you to $0 later. A quick micro story. Last week, a viewer on a Tier 4 inhaler and a Tier 3 DOAC paid coinsurance on both, bouncing between $85 and $130 per fill. We ran a benefit check and found a Tier 3 preferred inhaler with a flat $47 copay and confirmed no new prior auth. The doctor agreed the switch was clinically fine. Annual pre-cap savings, just over $600. Same outcomes, less chaos. If your plan resists a tiering exception when a true alternative isn't appropriate, escalate with your prescriber's notes. You want the letter to include diagnosis, prior therapies tried, clinical rationale for staying on the current drug, and the financial harm of higher tiering. Ask specifically for a tiering exception to match the cost sharing of the preferred alternative. If denied, request peer-to-peer review. Persistence pays. Finally, bake this into your yearly routine. During your annual plan audit, for each brand or biologic, collect the plan's preferred alternative name, the authorized generic status, any biosimilar preference, and the exact per fill cost at a preferred pharmacy. Keep that on your one-page cheat sheet. If prices jump mid-year, you're one call away from a clinically sound, lower-tier substitute. Remember the mantra, same outcome, lower tier, predictable copay. That's how you slash pre-cap spending without sacrificing care. Assistance stack, manufacturer, foundation, and state aid. You've pulled every lever inside the plan, timing, pharmacy, tiers. Now let's stack outside help that lowers cash pain without accidentally breaking your Part D math. The move is simple. Build a 3-layer assistance stack. Manufacturer programs, independent foundations, and state pharmaceutical aid. Then use each in the right scenario so you pay less now and still reach the $2,000 cap when you need to. This is how you protect your health and your wallet at the same time. Start with manufacturer patient assistance programs for brand drugs. These programs are usually for people with lower to moderate incomes or facing extreme out-of-pocket costs. They're most powerful for high-cost brands and specialty meds. The thing most people miss is eligibility varies by drug and manufacturer, and some programs won't help if you have Part D unless you meet financial hardship criteria. What to do today? Search the manufacturer's patient assistance page for your exact drug name. Call their hotline and ask 3 questions. Do you assist Part D members? What are the income and documentation requirements? Does the assistance provide free drug or reimburse pharmacy costs? If they supply the medication directly, that month's fill won't count toward Troop. So use this when you're not aiming to hit the $2,000 soon or when cash flow matters more than reaching the cap. Next, manufacturer copay cards. For most Part D situations, these can't be used at the Part D point of sale, and amounts paid with these cards typically don't count toward your Troop. Translation: they lower cash price, but they don't move you toward the $2,000 cap. Use them carefully. If you're in a month where you won't rely on Troop, say you're between appeals or stuck awaiting prior authorization, copay cards can bridge the gap. Keep receipts separate. When you return to covered fills, confirm with your plan that your Part D accumulators are correct. Always ask the manufacturer rep. Is there a version of support that works with Medicare patients directly, like free drug through a nonprofit pharmacy? If yes, pivot to that path. Now, independent charitable foundations. These are disease-specific funds that help with premiums or copays for eligible diagnoses and incomes. They're different from manufacturer cards and may work alongside Medicare. The move here is speed and timing. Funds open and close quickly when money runs out. Sign up for waitlist alerts through the foundation websites tied to your condition. Ask your prescriber's office if their social worker tracks fund openings. Many do. When a fund opens, apply the same day. If approved, you can often get copay assistance that works at your regular pharmacy for covered Part D drugs. Critical note, confirm with the foundation and your plan whether these payments count toward TROOP. Some do, some don't. If they don't, weigh whether the immediate relief still helps your budget while you work the plan's exceptions to get back onto TROP-eligible fills. State pharmaceutical assistance programs are the sleeper win. Some states offer help with Part D premiums and copays, or secondary wraparound coverage that reduces what you pay before you hit $2,000. The names differ: New Jersey PAAD, New York Epic, and others, but the idea is similar. If you qualify by income and residency, your net costs drop, and you often get special enrollment flexibility. Action step: search your state pharmaceutical assistance program or call your state health insurance assistance program, SHIP. Ask, do you help with Part D premiums or copays? Do you coordinate benefits? So my covered costs still count toward TROOP? Are there income tiers that change the benefit level? If your state program wraps your costs but still routes claims through Part D, you may hit the $2,000 with less pain. If it pays outside Part D, you'll save cash but may not advance toward the cap. Choose based on your expected year. If you won't reach $2,000 regardless, cash relief wins. If you will, favor options that count toward TROOP. 2 practical checklists to avoid common mistakes. First, documentation. Keep a single folder, digital or paper, with copies of approval letters, foundation grant amounts, and any pharmacy receipts paid by assistants. When prices look off, you'll have proof ready. Second, coordination. Tell your pharmacist about any foundation grant ID so they can bill it correctly. If they look confused, ask the plan or foundation for the correct bin/PCN and processing notes. Let's connect this to your refill calendar. Use manufacturer-free drug months when you're not on pace to hit the cap or while appeals process. Use foundation help when your diagnosis qualifies and funds are open, especially for steady monthly meds where predictable support stabilizes your budget. Layer state programs as a backbone: premium help plus lower copays. Then let Part D process claims so covered amounts still move you toward $2,000 when that's your strategy. One micro story. A viewer on a costly biologic faced a tier jump mid-year. Their doctor filed a tiering exception, but approval would take 2 weeks. We stacked. A foundation grant covered that month's fill at the preferred pharmacy. Then the exception kicked in the next cycle, shifting to a lower copay that counted toward TROOP. Net result: no treatment gap, cash saved now, progress toward the cap later. Bottom line: assistance isn't one thing, it's a stack. Manufacturer programs for big ticket relief, foundations for diagnosis-based support, and state aid for ongoing savings. Use the right layer at the right time, confirm TROOP impact each month, and your pre-cap pain drops without losing the path to $2,000. Cash versus insurance versus coupons. When to bypass your plan. Here's the rule of thumb you'll use for the rest of your life. If a fill isn't helping you reach the $2,000 cap or is priced worse than a cash option, run the numbers and consider bypassing the plan for that month. We're not guessing. We're deciding based on TROOP impact, timing to cap, and the cheapest safe path today, so you never pay a convenience tax again. Start with a quick decision tree you can do on the phone at the counter. Ask 3 questions. Is this drug covered by my plan right now? If yes, what's my member price today at a preferred pharmacy? Does this fill move me meaningfully toward the $2,000 cap this year? If the answers are covered, fair price, and yes, you stay in the plan. If the plan price is ugly, or this drug won't push you to the cap anyway, you check cash and coupon routes. Cash price means you pay the pharmacy's price with no insurance. Coupon price means you use a discount card like GoodRx, Single Care, or a store program that sets a lower cash price. Important, most coupon transactions don't count toward Troop. That's not always bad. If you're nowhere near $2,000 this year, say you're on one brand and a few generics, grabbing a $12 coupon fill that beats your $28 copay is a straight win. But if you will hit the cap, keeping expensive fills inside Part D matters, because Troop progress turns the rest of your year to dollar. Let's make this practical with a 3-scenario playbook. Scenario 1, stable generic. Your plan wants $9, your preferred pharmacy's cash price is $18, and a coupon brings it to $5. If you won't hit $2,000, take the $5 coupon. If you might hit $2,000, do the math. That $4 difference multiplied by 12 is $48. Usually not worth giving up Troop on a drug that won't move the needle. In that case, pay the $9 on plan and keep everything tidy. The shortcut, if the on-plan generic is under $10 and you're a candidate to hit the cap, stay on plan for simplicity and Troop cleanliness. Scenario 2, non-formulary or prior auth delay. Your doctor prescribed a brand inhaler. The plan slapped on prior auth and says approval takes a week. The cash price with a coupon is $120 instead of the plan's $240. You need the medication now. This is where bypassing the plan for one fill makes sense. Ask your prescriber for samples to bridge the gap. If none, use the coupon for this month only, save the receipt, and resume on plan the moment prior auth is approved so future fills count toward your $2,000. Document the dates so you can push for an earlier effective date if appropriate. Scenario 3, high-cost brand where you'll hit $2,000 early. You're on a specialty oral drug that will push you to the cap by March. Plan price at a preferred pharmacy is $1 after you hit the cap, but $600 per fill beforehand. A coupon offers $380, but won't count toward Troop. The move is to stay on plan, even if the pre-cap price stings, and opt into smoothing, so you spread those dollars across the year. Taking the $380 coupon slows your march to $2,000 and costs more overall. Here's the quick script at the counter. Say, what's my on-plan price today? Is this your preferred rate for my plan? Can you also check the store's cash price? Then pull out your phone and check one coupon app. If the coupon beats the on-plan price by $15 or more and you won't hit $2,000, consider using it. If you will hit $2,000, ask yourself, does this fill move me closer? If yes, stick with Part D and request smoothing. If no, maybe it's an occasional antibiotic. Use the coupon and keep it separate from your chronic meds. 2 safety notes. 1, never bypass your plan for drugs that need coordination of benefits, split billing, or narrow therapeutic index without talking to your prescriber. Think anti-rejection meds, complex oncology regimens, or anything with tight monitoring. 2, don't split the same drug between cash and insurance within the same month. It confuses refill timing and can trigger early fill denials later. Keep each medication on one path per cycle. Peace of mind, penny mistakes. A quick micro story. A viewer's tear. 3 gout med jumped to $86 1 month due to a negotiated price change. They checked a coupon and saw $22. They won't hit $2,000 this year. They used the $22 coupon for that month only, then asked the plan for a lower tier alternative for next month. Net, $64 saved immediately, then a switch to a Tier 2 option with a $7 copay going forward. Finally, build a tiny rule card and keep it in your wallet. Will I hit $2,000? If yes, keep high-cost fills in Part D and use smoothing. If no, compare on-plan versus coupon and pick the cheaper safe option. Always verify preferred pharmacy status first. Get a reference number when prices look off. That's how you bypass on purpose, not by accident. One-page med cost dashboard. Control at a glance. Let's pull everything you've learned into one simple page you can glance at and immediately know what each drug costs this month, which pharmacy to use, whether smoothing is on track, and what to do if a price jumps. You'll build it once, update it in 1 minute a month, and it keeps you in control. No more surprise swipes at the register. Start with the top strip, 3 numbers. Left box, year-to-date toward $2,000. Middle box, estimated month you'll hit $2,000 based on current spending. Right box, smoothing status, on or off, and the expected monthly draft amount. If you didn't opt into smoothing and you're on track to hit $2,000 before summer, circle Enroll this week. That's your cash flow safety net. Next, your drug table. 4 columns, 1 row per medication. Column 1, drug name and strength, exactly as on the label. Column 2, tier and restriction. Write T3, no PA, or T4, PA plus QL. Column 3, cheapest source this month. Write Big Box Preferred 30D, $47, or Mail 90D, $12. Column 4, next action. Examples: Ask MD, auth generic, test claim at Pharmacy B, or file tiering exception if price greater than $75. Keep it short and specific so you can act fast. Below the table, a pharmacy map. List your 3 pharmacies with their status for your plan. Store A, preferred. Store B, preferred. Store C, standard. Add store phone numbers and hours. If store A is preferred and delivers, write delivery. Yes. That solves rides and weather problems without paying the standard tax. Now, add a timing strip for the month. A simple calendar line with 4 marks. Brand A refill date, Brand B refill date, generic batch, and smoothing draft date. Your goal is to cluster high-cost fills early if you'll hit the cap, or separate them if you won't. Write a tiny note if you change timing. Moved inhaler to first week, align with DOAC, or push generic to week 3. On the right side, put your price check script. It's 2 lines you'll read to the plan or pharmacist. Please run a real-time benefit check for drug X, 30-day at Pharmacy A and Pharmacy B. Confirm member price and stage today. If the price is higher than Plan Finder, can you verify NDC, day supply, and preferred status? Reference number, please. This is your fast path to matching the promised price. Add a trigger box, 3 red flags that force action. 1. Any price jump over $15 on a brand. 2. A PA/QL/ST added, note in a plan letter. 3. Pharmacy shows as standard on your plan page. If any trigger hits, go to the Fast Fix checklist directly under it. 1. Call plan for test claim and reference number. 2. Request transition fill if changed. 3. Ask prescriber for tiering exception or plan preferred alternative. 4. Temporarily use coupon only if you won't hit $2,000 and you need the drug now. Under that, keep your savings switches list. It's a short list of green light alternatives your prescriber already approved. Example: if Trelegy price greater than $75, okay to switch to plan preferred Combo X. If Eliquis price spikes, okay to consider Xarelto, call MD first. Next to each, note the expected copay at your preferred pharmacy. When a month goes sideways, you're not starting from 0. At the bottom, put monthly 2-minute update. It's 4 boxes you'll initial after the first refill each month. Box 1, check preferred status for my store. Box 2, confirmed smoothing draft matches plan. Box 3, logged YDD toward $2,000. Box 4, prices matched dashboard. If something didn't match, circle it and flip the page over. Write the plan call reference number and what they promised. 2 pro tips make this dashboard fireproof. First, print your plan's evidence of coverage PDF page that lists your drug tiers and keep it stapled behind the dashboard. When a phone rep disagrees, you can quote the page number. Second, put your state ship phone number and your plan's member services on the top margin. When you're in a line at the pharmacy and something's off, you've got the numbers right there, so you can fix it before you pay. Finally, keep it visible. Tape it inside a kitchen cabinet or save it as the first page of a simple binder labeled Part D 2025. Update the YDD and the next refill dates the same moment you unload your meds at home. This is how you shift from reacting to steering. 1 page, 5 minutes, and your drug costs stop ambushing you. Case Study 1, single high-cost specialty drug. Let me walk you through a clean, real-world composite so you can mirror the exact moves. 1 drug, sky-high sticker, and a plan that either makes your year manageable or miserable. We'll call her Linda, 71, on original Medicare with a standalone Part D plan, taking 1 specialty oral cancer medication filled monthly at home. She also has 2 low-cost generics, but those don't drive the math. This is the perfect test for the $2,000 cap and the smoothing program. January 2nd, Linda opens Medicare's Plan Finder with 3 pharmacies selected, her usual neighborhood chain, a big box that often shows preferred, and a regional grocery store. She enters her specialty drug by exact name, strength, and 30-day quantity. She toggles pharmacies and sorts plans by lowest drug plus premium cost. 2 plans float to the top. Plan A shows an estimated annual drug plus premium cost a few hundred lower than Plan B. But Linda doesn't stop there. She clicks into the details. What she sees is the difference between pain and predictability. Plan A applies the full deductible to Tier 5 and shows coinsurance on the specialty drug until she reaches the cap. The January per fill estimate is high, with a second high fill in February, and then it drops to $1 after hitting $2,000. Plan B has a slightly higher premium but lower coinsurance on Tier 5 and better preferred pharmacy pricing. In January, Plan B's first fill is still large, but the second fill is smaller, and she hits $2,000 midway through February. That means every fill from March through December is $1. Now, the pharmacy effect. At Linda's neighborhood chain, both plans price higher. At the big box preferred location, Plan B's negotiated rate is better, shaving a couple $100 off the pre-cap total. At the regional grocery, Plan A wins on the first fill but loses on the second. The takeaway is clear. She'll use the big box preferred pharmacy under Plan B to minimize what she pays on the way to $2,000. Before deciding, Linda calls both plans for a real-time benefit check. She asks each to run a test claim for the exact drug 30-day supply at both pharmacies. Plan A quotes a January member price that's $90 higher than Plan Finder showed. Why? Different NDC. The rep reruns with the NDC most likely on shelf at the big box, and the price matches the site. Reference number noted. Plan B matches Plan Finder. First try. Reference number noted. She also asks both plans about smoothing. If I opt in before my first fill, what will my monthly draft be? Plan A estimates roughly $180 per month after the initial bill. Plan B comes in closer to $165 because of the lower pre-cap pricing at the preferred pharmacy. Lower and steadier wins. Linda enrolls in Plan B, opts into smoothing immediately, and calls her oncologist's office. She confirms prior authorization is required and asks them to submit it that day with diagnosis codes, treatment plan, and urgency note. She asks the plan whether a quantity limit applies. It doesn't. She schedules her first fill for the first week of January at the big box preferred pharmacy. Her dashboard now shows year-to-date $/$2,000, estimated cap date mid-February, smoothing on, expected monthly draft $165. Here's where timing amplifies savings. Linda clusters her first 2 fills in January and early February to reach $2,000 as fast as clinically safe. Because smoothing is active, those big claims don't crush cash flow. They convert into the steady monthly draft. By March, she pays dollar at the counter for the specialty drug, and her smoothing draft continues evenly through December. Her 2 generics, 90-day mail is cheaper and predictable, so she keeps them by mail and ignores them for troop strategy. They barely move the needle. Midyear, the plan sends a notice. A preferred biosimilar is now available and will be Tier 5, but with a slightly lower negotiated rate. Linda calls her oncologist. Is the biosimilar clinically appropriate? The doctor prefers not to switch mid-response. Linda documents that and keeps the originator, which is covered and remains dollar after cap anyway. No disruption, no surprise bills. What if prior authorization had delayed the first fill? Linda's office would have requested a transition fill or samples. If neither, she would have used a coupon for a one-time bridge only if clinically necessary and documented dates, carefully, then flipped back to Part D as soon as PA cleared, so the next fills counted toward $2,000. Let's tally the win. The wrong plan with a standard pharmacy would have stacked higher coinsurance on a worse negotiated rate, pushing her pre-cap spend hundreds higher. The right plan plus preferred pharmacy plus smoothing front-loaded the path to $2,000, stabilized cash flow, and turned the rest of the year to dollar at the counter. One phone call, 2 toggles in Plan Finder, and a calendar nudge turned a terrifying drug into a manageable line item. Case Study 2. Mixed basket of 8 generics plus 2 brand meds. Now, let's tackle the most common scenario, a mixed basket. We'll call him David, 73. He takes 8 generics daily: blood pressure, cholesterol, thyroid, reflux, a diuretic, metformin, vitamin D, and an antidepressant. Plus 2 brands, an inhaler combo and a DOAC blood thinner. He doesn't want drama, just steady costs and no surprises. David starts where you will, Plan Finder, with 3 pharmacies selected, his neighborhood store, a big box that's usually preferred, and a national chain near his doctor. He enters exact drugs, strengths, and quantities. Most generics 90-day, the brands 30-day. He sorts by lowest drug plus premium cost and opens the top 3 plans in new tabs. Plan X looks great on premium, almost nothing, but shows a full deductible that hits Tier 3 and above. His 2 brands sit in Tier 3 and Tier 4 with coinsurance. January estimates are ugly. He pays the deductible on the inhaler, then a percentage on the DOAC. Plan Y has a slightly higher premium, waives the deductible for Tier 1 to 2 generics, and offers flat copays on Tier 3. The DOAC still sits on coinsurance, but the inhaler drops to a predictable copay at a preferred pharmacy. Plan Z splits the difference with decent premiums and better DOAC pricing, but it pushes the inhaler to Tier 4 with prior authorization. Here's the first win: pharmacy toggles. At his neighborhood store, Plan X is cheapest on generics, but worst on the brands. At the big box preferred, Plan Y cuts the inhaler by roughly half versus the neighborhood store and keeps the DOAC competitive. The national chain ties on generics, but loses on both brands. David writes down per fill numbers for January and March to spot the deductible hit and the post-deductible pattern. He pressure tests with real-time benefit checks. He calls Plan Y. Please run a test claim for the inhaler 30-day at the big box in my neighborhood store, and for the DOAC the same way. The rep quotes a $47 copay for the inhaler at the big box and nearly double at the neighborhood store. The DOAC is 25% coinsurance on a negotiated rate that's about $20 lower at the big box. Reference number saved. He calls Plan Z. They confirm prior authorization on the inhaler and a higher allowed price on the DOAC. That's 2 strikes. This is where split pharmacy strategy shines. David decides. Brands at the big box preferred. Generics wherever is simplest and cheap. Surprisingly, the national chain offers a $$2 copay on several Tier 1 generics with plan-wise preferred status. He locks 90-day, fills there for the generics, sets calendar reminders, and keeps the brands monthly at the big box. Now, he dials in timing, because he probably won't hit $2,000 with this basket. The smoothing program isn't necessary, but he still clusters the inhaler and DOAC in the first week of each month, so he can check prices once and move on. He avoids 90-day on the brands because plan-wise 90-day coinsurance would amplify any allowed price bump. For generics, he uses 90-day because the total is cheaper and fewer trips mean fewer chances for errors. Drug optimization is next. He asks his prescriber, is there a plan-favored alternative inhaler on Tier 3 with a flat copay? The doctor confirms the current inhaler is already the plan's preferred option, so no change. For the DOAC, the plan shows the competitor on the same tier, but with a slightly better negotiated rate at the big box. The prescriber says either is clinically fine. David notes, if price jumps, okay to switch. He doesn't switch today. No need to fix what isn't broken, but he has a green light backup. He builds the 1-page dashboard. Top strip, year-to-date toward $2,000, estimated hit date, unlikely this year, smoothing off. Table lines list drug, tier/restriction, cheapest source, next action. For the inhaler, T3, no PA, big box preferred $47, recheck in October. For the DOAC, T3 coinsurance, big box preferred 25% of allowed. If price greater than $85, call plan for test claim and ask about therapeutic alternative. For each generic, T1, no PA, national chain $90, $6, auto refill. Trigger box says, any brand price jump greater than $15, call plan, get reference number, consider alternative. He adds the cash bypass rule card to his wallet. If a generic rings up higher on plan than a $5 coupon, he'll use the coupon only if he's not chasing $2,000. For the brands, he stays on plan, so everything counts toward troop in case a mid-year change pushes his spending higher than expected. Mid-year, a plan notice arrives. The inhaler will require step therapy starting August. Trigger fired. David calls the plan, requests a transition fill, and his prescriber sends documentation that he's stable and has tried alternatives. The plan grants a step therapy exception, cost stays at $47, and there's no treatment gap. He logs the reference number on his dashboard. By October, he reruns Plan Finder. Plan Y still wins on total annual cost with his split pharmacy setup. If that ever flips, he'll switch plans during the annual enrollment period, keep his pharmacies, and carry over the dashboard format. What did this save? Versus sticking with the low premium, high deductible plan and a standard pharmacy, David avoids the January deductible hit on the inhaler, lowers the DOAC base price with preferred status, and locks the generics into $6 90-day cycles. That's hundreds back in his pocket, zero change in outcomes, and no monthly drama. That's the mixed basket blueprint you can copy today. Case Study 3, multiple chronic conditions with low income. Let's map a tougher, very common situation. We'll call her Rosa, 76. She has diabetes on insulin, COPD with a daily inhaler, heart failure on several generics, and atrial fibrillation on a DOAC. Income is tight from Social Security, small savings, and rent. She can't tolerate cash flow spikes. The plan must be predictable, pharmacy must be nearby, and she needs every discount that actually works with Medicare. Rosa starts with 3 moves the minute Plan Finder opens. 1. She enters every medication with exact strength, form, and quantity, including test strips and lancets, because diabetes supplies run through Part D when they're not durable equipment. 2. She adds her neighborhood pharmacy, a nearby big box that often shows preferred, and 1 grocery chain. 3. She turns on the pay over time, smoothing concept in her notes, because if she reaches $2,000, monthly drafts will matter more than the timing of individual refills. Now, the insulin rule kicks in. Every plan shows insulin at $35 per month in 2025. That simplifies 1 pillar. For the inhaler and DOAC, tiers and negotiated rates vary a lot. She sorts by lowest drug plus premium cost, then opens the top 3 plans. Plan 1 has a very low premium, but a deductible that hits tier 3+. The inhaler and DOAC both touch the deductible and sit on coinsurance. Plan 2 has a slightly higher premium, waives the deductible for tier 1 to 2 generics, keeps insulin at $35, and places her inhaler on tier 3 with a flat copay at preferred pharmacies. The DOAC is still coinsurance, but on a better negotiated rate. Plan 3 bundles attractive extras, but makes the inhaler tier 4 with prior auth. Rosa toggles pharmacies on each plan page. At her neighborhood pharmacy, Plan 1 looks cheapest on generics, but worst on the inhaler and DOAC. At the big box preferred, Plan 2 cuts her inhaler to a steady copay and lowers the DOAC base by roughly $15 per fill versus the neighborhood store. The grocery chain ties on insulin, but loses on the DOAC. She writes January and March per fill numbers for inhaler and DOAC to see the deductible hit. Plan 2 at the big box is winning on predictability. Cash flow is fragile, so she pressure tests with a real-time benefit check. She calls Plan 2. Please run a test claim for my inhaler and DOAC, 30-day supply at the big box and at my neighborhood store. The rep confirms the inhaler is a flat $47 at the big box and almost double at her neighborhood store. The DOAC is 25% of an allowed price that's cheaper at the big box. Reference number captured. She asks about smoothing. If she reaches $2,000 by late summer with her combined meds, what would the monthly draft be if she opts in now? The estimate is around the premium plus a steady draft based on expected utilization. That steadiness matters more than chasing a tiny premium discount. Next, she checks extra help, low-income subsidy. With tight income, there's a real chance she qualifies. She calls Social Security or applies online, and also phones her state health insurance assistance program for guidance. If approved for extra help, her premium could shrink and copays drop to set amounts. She reruns Plan Finder with extra help toggled because the best plan can flip under LIS. In one run, a plan that looked average becomes excellent when LIS pricing applies, cutting the DOAC coinsurance to a small fixed copay and trimming inhaler costs. She layers state pharmaceutical assistance. In states like New York Epic or New Jersey PAAD, benefits can wrap Part D copays or premiums and sometimes offer enrollment flexibility. She asks 3 questions. Do you help with Part D cost sharing? Do your payments still route claims through Part D? So costs count toward troop? What are the income tiers? If the state plan coordinates correctly, she gets lower monthly bills while still marching toward $2,000 if her meds push her there. If coordination is outside Part D, she may save cash, but not advance toward the cap. Fine if she won't hit $2,000. Less ideal if she will. Now, pharmacy strategy. Rosa can't travel far, so convenience matters. She asks her neighborhood pharmacy, "Are you preferred for my plan?" They're standard. She checks if another location in the same chain is preferred. There's 1-2 bus stops away that delivers. That solves transport and locks preferred pricing. She sets insulin and generics on 90-day cycles if cheaper. Inhaler and DOAC monthly at the preferred store for tighter control. Drug optimization comes next. She asks her prescriber whether a plan preferred inhaler exists on Tier 3 with a flat copay. If yes and clinically appropriate, they switch. For the DOAC, the prescriber confirms both options fit her profile. Rosa sticks with the one the plan prices better at the preferred store. She doesn't chase coupons for these two because she may hit the cap and wants every dollar to count toward troop. If she has a non-covered occasional med, she'll use a coupon only when it won't interfere with. Reaching $2,000. She builds the one-page dashboard. Top line shows year-to-date toward $2,000. Likely cap month, uncertain. Smoothing on table entries. Insulin $35 at preferred. Inhaler T3 flat $47. DOAC coinsurance 25% at preferred with allowed price noted. Generics $1.06 on 90-day cycles. Trigger box lists. Any price jump over $15. Any PA/QL letter. Pharmacy status change. Plan and state assistance phone. Numbers sit at the top margin. 2 micro moments keep costs low. First, she times her inhaler and DOAC in the first week monthly, so she sees both prices in one call if anything shifts. Second, when a letter adds step therapy to the inhaler, she requests a transition fill. Her doctor submits stability notes, and the plan grants an exception. No skipped doses, no cash price surprise. Add it up without extra help or state assistance. Plan 2+ preferred delivery, stable copays, and smoothing holds her monthly outlay steady and trims pre-cap pain. With extra help or state wrap, her monthly bills drop even further and stay predictable. Rosa keeps clinical stability, avoids bus rides and bad weather, and turns a scary stack of meds into a budget she can live with. The 12 expensive mistakes to avoid this year. Mistake 1. Sorting plans by premium only. Low monthly stickers hide high deductibles, coinsurance, and bad pharmacy pricing. Always sort by lowest drug plus premium cost. Then check per fill prices for your 2 most expensive meds at your chosen pharmacies. Viral tip: premium is not price. Mistake 2. Ignoring preferred versus standard pharmacy status. Same plan, 2 counters, wildly different prices. Confirm your store is preferred for your plan each January and anytime a receipt looks odd. If not, switch to a nearby preferred location or split fills by drug. Mistake 3. Assuming mail order is always cheaper. For brands with coinsurance, 90-day mail can cost more than 3 30-day preferred retail fills. Run a test claim for 30-day preferred retail, 90-day preferred retail, and 90-day mail before deciding. Mistake 4. Failing to pressure test with a real-time benefit check. Plan Finder is great, but negotiated rates and NDCs vary. Call your plan, run test claims for your top 2 drugs at 2 pharmacies, and get a reference number. If numbers don't match, fix it before you fill. Mistake 5. Letting the deductible surprise you. Many plans apply it to Tier 3 to 5. If you take a brand, you may pay the full deductible first. Favor plans with flat copays on your brands or that waive the deductible for your tiers. Time expensive fills to hit the cap faster, if appropriate. Mistake 6. Chasing coupons that don't fit your strategy. Most coupon or manufacturer card fills don't count toward troop. If you'll hit $2,000, keep high-cost fills inside Part D and use the smoothing program. Use coupons only for non-covered or occasional meds when you won't reach the cap. Mistake 7. Never asking about therapeutic alternatives. Plans prefer certain options within each class. Ask your plan and prescriber for a lower tier alternative, an authorized generic, or a preferred biosimilar. One phone call can swap coinsurance for a predictable copay. Mistake 8. Sticking to one pharmacy out of habit. Split fills. If drug A is cheapest at the big box preferred, and drug B ties elsewhere, run drug A there, and everything else where service is best. Transfers are routine. Controlled substances may need a new script. Ask your prescriber. Mistake 9, forgetting utilization management landmines. Prior authorization, step therapy, and quantity limits can stall access and add costs. Before January fills, check your drugs for PA/QL/ST on your plan page. If added mid-year, request a transition fill and have your doctor submit documentation fast. Mistake 10, not enrolling in the smoothing program when cash flow is tight. If you'll approach $2,000, smoothing converts spikes into steady drafts. You must opt in with your plan. Do it before your first big fill of the year, so January doesn't wreck February's budget. Mistake 11, ignoring state and extra help eligibility. Extra help in state programs like New York Epic or NJPAD can slash premiums and copays, sometimes change your best plan, and offer enrollment flexibility. Rerun Plan Finder with LIS. If you qualify, your top choice may flip. Mistake 12, waiting until October to discover a bad fit. Rerun your mini audit whenever a drug is added. A price jumps more than $15 or a letter adds PA/QL/St. 10 minutes now beats 12 months of overpaying. Keep your one-page dashboard updated and your plan's evidence of coverage handy. Quick safeguard checklist you can copy today. 1. Confirm preferred pharmacy status and delivery options. 2. Run test claims for your 2 priciest meds at 2 pharmacies. Save reference numbers. 3. Decide 30-day versus 90-day by actual per fill math, not habit. 4. List plan preferred alternatives for each brand with your prescriber's green light. 5. Opt into smoothing if your YDD pace suggests you'll hit $2,000. 6. Add your state program and ship numbers to your dashboard. 7. Set 2 calendar alerts, 5 days before your brand refills and the day you're smoothing draft posts to catch errors in real time. Share this checklist with a friend. Help them keep their money, too. If you remember nothing else, premium is not price, convenience can be costly, and small checks prevent big bills. Avoid these 12 traps, and you'll keep more cash for what actually matters this year. 30-day action plan, from confused to confident. Day 1, build your one-page dashboard. Write 3 boxes across the top. Year-to-date toward $2,000, estimated month you'll hit $2,000, and smoothing status. Under that, list each medication with tier, any restriction, cheapest source this month, and a next action. Add your 3 pharmacies with preferred or standard labels and phone numbers. Tape this inside a cabinet or save as page 1 of your binder. Day 2, prep your exact drug list. Pull every bottle. Write drug name, strength, form, and monthly quantity. Add test strips and lancets if you use them. Star any brand name or anything that might be tier 3 or higher. Note your refill dates for the next 60 days. Day 3, add your 3 pharmacies. Choose your current store, a likely preferred big box, and a national chain with long hours. If transportation is tough, pick options that deliver. Put their store hours and delivery notes on your dashboard. Day 4, run Medicare's Plan Finder. Enter your exact drug list and those 3 pharmacies. Sort by lowest drug plus premium cost. Open the top 3 plans in new tabs. Capture the annual total for each plan at each pharmacy. Day 5, drill into per fill math. For your 2 most expensive meds, click into the plan details and write the January and March member price at each pharmacy. This shows deductible exposure and whether costs stabilize. Day 6, read deductible rules. Highlight if your brands hit the deductible and whether the plan uses flat copays or coinsurance on those tiers. Favor flat copays for predictability. Day 7, Identify your split pharmacy win. If drug A is cheapest at the big box and drug B ties elsewhere, circle split fills okay. Add that to your dashboard. Day 8, call the top 2 plans for a real-time benefit check. Ask them to run test claims for your top 2 meds at 2 pharmacies. Confirm member prices match Plan Finder. Get reference numbers and write them on your dashboard. Day 9, ask about alternatives. On the same calls, say, is there a lower tier alternative, an authorized generic, or a preferred biosimilar? Write exact names and copays. Note if a tiering exception is likely with doctor support. Day 10, decide 30-day versus 90-day by drug. If a brand uses coinsurance or 90-day is pricier, stick with 30-day. If a generic is cheaper at 90-day, switch. Record your cadence on the dashboard. Day 11, choose your plan. Pick the lowest total cost with predictable copays and the fewest restrictions on your list. Write the plan name, premium, deductible rules, and per fill prices for your top 2 meds on your dashboard. Day 12, enroll and download documents. Save the summary of benefits and evidence of coverage as PDFs. Put the file path on your dashboard. Set a calendar reminder to verify the first fill matches. Day 13, opt into smoothing if you'll approach $2,000. Call the plan and enroll before your first big fill. Write the expected monthly draft on the dashboard. Day 14, confirm pharmacy status. Call your chosen stores. Are you preferred for my plan? If your favorite is standard, ask if another nearby location in the same chain is preferred and delivers. Update your dashboard. Day 15, sync refills. Move expensive meds to the first week of the month if you'll hit $2,000. Spread them if you won't. Note dates on your calendar strip. Day 16, prescriber alignment. Send a concise message. Plan shows drug B at lower tier with a $47 copay at preferred pharmacy. Clinically appropriate to switch. Attach any plan guidance. Day 17, prior authorization scan. On your plan page, check each drug for PA, step therapy, or quantity limits. If flagged, ask your prescriber to submit documentation now. Note, PA sent on your dashboard. Day 18, build your price check script. Add it to the right side of the dashboard. Run a real-time benefit check for drug X, 30-day at pharmacy A and B. Confirm NDC, day supply, stage. Reference number, please. Day 19, assistance stack quick check. If you use high-cost brands, visit the manufacturer site for patient assistance programs and note eligibility. Sign up for foundation alerts tied to your diagnosis. Call your state health insurance assistance program about state pharmaceutical aid. Day 20, first refill verification. At pickup, call the plan from the counter if the number doesn't match. Use your script. Get a reference number. Update your dashboard. Day 21, lock refill cadence. Turn on auto refill for stable 90-day generics at the cheapest preferred pharmacy. Keep brands manual for monthly price checks. Day 22, add your trigger box. Write, price jump over $15, PA/QL/ST letter arrives, or pharmacy loses preferred status. Under it, list your fast fix steps. Day 23, create your wallet rule card. Front, will I hit $2,000? If yes, keep big fills in Part D plus smoothing. If no, compare on-plan versus coupon. Back, plan member ID, plan phone, ship number. Day 24, test a transfer. Move one generic to the cheaper preferred location to confirm transfer speed. Note any issues. Day 25, practice a tiering exception. Draft a template letter with your prescriber. Diagnosis, drugs tried, rationale, financial impact, and the ask, tiering exception to match preferred alternative cost sharing. Day 26, rerun Plan Finder if anything changed. New drug, dose change, Update and confirm you're still on the best setup. Day 27, micro drill on inhaler or DOAC technique. Ask your pharmacist for a 2-minute check. Proper use avoids waste and early refills. Day 28, confirm smoothing draft. Verify the amount and date match your dashboard. If off, call and fix. Day 29, snapshot your wins. Total your first month savings from preferred pricing, cadence changes, and any alternative switches. Day 30, set 2 recurring reminders. Monthly 2-minute update after your first refill and an October Plan Finder rerun. You're not guessing anymore, you're steering. Pro moves, negotiation, appeals, and advanced timing. You've got the fundamentals: preferred pharmacies, test claims, smoothing, and alternatives. Now let's level up with the pro moves that convert "I hope this works" into "I know this will work." These are the playbooks I use when plans push back, when timing can chop hundreds off the path to $2,000, and when a 2-paragraph appeal flips a denial. Start with negotiation at the counter, the quiet, legal kind. Ask for a DAW override, only when your prescriber wants the brand and the plan requires the exact NDC. Otherwise, you're just paying more. Ask the pharmacist to try a different NDC for the same drug strength if the plan's rate is clearly off from Plan Finder. Sometimes the wholesaler's NDC on the shelf price is worse than the alternative the store can order by tomorrow. If the store can't match the preferred rate you saw online, request they reprocess with the plan's preferred billing notes. Many chains have an internal plan pricing tip sheet. You're not haggling. You're getting the contract applied correctly. Now the escalation route with your plan when prices don't match. Step 1, real-time benefit check and reference number. Step 2, ask for the plan's pharmacy help desk to re-verify the claim with the store while you're on the line. Step 3, if still off, file a fast grievance. Pricing discrepancy versus Medicare Plan Finder and prior rep quote, reference number X. Grievances create timestamps and deadlines. Plans move faster when there's a clock. If the plan acknowledges an error later, ask for a price correction and refund adjustment on the claim. Appeals are where most people give up and where you can win. There are 2 flavors you'll use the most: coverage determination and tiering exception. Coverage determination is please cover this drug or remove the restriction. Tiering exception is I need the cost sharing of the lower tier because alternatives aren't appropriate. For coverage determinations, your prescriber's letter should hit 4 points in plain language: diagnosis and ICD-10 code, medical necessity for the requested drug, treatments tried and failed or contraindicated, and harm of delay. For tiering exceptions, add language that specifically names the plan's preferred alternative and why it's not appropriate: side effects, interactions, prior failure, or unique clinical benefits of the requested drug. Ask the plan for the exact fax number, form, and any required chart notes so your prescriber sends it right the first time. Use timelines to your advantage. Standard determinations usually have a set window. Expedited requests require documenting that delay risks serious harm. If your prescriber documents risk of hospitalization or loss of function, the plan has to move. If they deny expedited handling, appeal that denial by phone the same day. Keep your reference numbers lined up on your dashboard. The peer-to-peer call is the hidden lever. If a denial arrives, ask the plan for a peer-to-peer review between your prescriber and the plan's clinical reviewer. Your prescriber should bring 3 bullets: the failed alternatives, the clinical rationale tied to guidelines, and the patient-specific risk of switching. Pro tip: prescribers can ask for the reviewer's specialty. If you're on a complex biologic, you want someone in the right field. After the call, ask your prescriber's office to send a brief post-call summary as an addendum. Sometimes that written record is the nudge that finalizes approval. While appeals move, your no-gap bridge plan keeps you safe. Request a transition fill if the plan changed coverage mid-year. Plans are expected to allow a temporary supply while you work the exception. If a transition fill isn't available, ask your prescriber for samples. If neither is possible, and you won't hit $2,000 this year, consider a one-time coupon fill to avoid a treatment gap. Then flip back to Part D as soon as coverage is restored so future fills count toward troop. Every time you bridge, write the date and receipt on your dashboard. Let's talk advanced timing, how the calendar saves you money. If you know you'll hit $2,000 this year, front-load the fills that do the heavy lifting. Align two higher-cost brands in early months so you reach the cap sooner, then coast at $4 covered drugs the rest of the year. If you won't hit $2,000, do the opposite. Spread high-cost fills away from the month when other expenses peak and avoid stacking 90-day supplies for brands that use coinsurance. For generics, if 90-day preferred is cheaper, cluster them in the same week to minimize pharmacy trips and pricing surprises. Use refill alignment and day supply switches surgically. On some plans, a 60-day supply on a brand can be worse than 2 30-day fills if coinsurance applies. On others, a 90-day preferred retail beats 3 separate trips. Run a test claim for 30-, 60-, and 90-day fills before you decide. And remember that smoothing spreads patient liability the same whether you do one big fill or 3 smaller ones. So choose the structure that gets you to $2,000 faster if that's your strategy. A quick micro case to show the timing math. A viewer on 2 brands hitting the cap by May was filling one in mid-month and the other at the end. They opted into smoothing and moved both to the first week. Result, they reached $2,000 in April instead, which turned May and beyond to dollar at the counter, while the monthly smoothing draft stayed steady. One calendar tweak, a full month of dollar fills unlocked. Negotiation with prescriber offices matters too. Ask for e-prescriptions to your preferred location and for dispense as written only when clinically necessary. Request that prior auth submissions include the plan's language verbatim. If the plan calls the alternative drug X 200 micrograms discus, that exact wording should appear in the notes to avoid nitpicks. If your prescriber staff is overwhelmed, offer to provide the plan's form, fax number, and prior notes you've collected to speed the process. When a plan rejects a tiering exception with boilerplate language, don't accept the first no. Ask for the criteria in writing and a copy of the clinical policy they used. Sometimes the policy permits exceptions for patients stable on therapy for 6 months or those with documented adverse effects to alternatives. Quote their own policy back in the appeal. It's not combative, it's precise. 2 final pro tools: SHIP and your state's consumer assistance. If a plan stonewalls or misapplies rules, your state health insurance assistance program can escalate. They know the plan liaisons and escalation channels. And if a pharmacy keeps processing at standard rates, even though your plan lists them as preferred, ask the plan to update the pharmacy's contract profile and reprocess claims retroactively. Yes, retroactive adjustments happen if you have your reference numbers. Put this all together, and it's simple. Verify price, document everything, align timing, and escalate with specifics. You'll either lower the bill immediately, reach $2,000 sooner with less pain, or both. That's how pros keep money in their pocket without sacrificing care. If you remember one thing, premium isn't price. Your total annual cost depends on pharmacy, tiers, deductibles, timing, and a few smartphone calls. If you want a custom walkthrough for your exact meds and zip code, watch the next video where I run live comparisons and scripts you can copy. Subscribe and share this with someone who's on Part D. One small change today can save them hundreds by next month.